Okay, now let's talk about external balance. So right before this, in the other video, we were talking about internal balance, how the body can shift potassium in and out of cells. But the big picture for internal balance is that net potassium didn't change. We're just moving it from one compartment to the other because that has electrochemical benefits for excitable cells. Okay. For external balance, now we're talking about the big picture, like all the potassium in the body, the total body potassium content. So this is about how do we hold on to more potassium if we need more potassium? How do we get rid of potassium if we have too much? Okay, so I mentioned that dietary intake is about 100 milliequivalents per day. So, but thinking about the GFR as high as it is, the filtered load of potassium is quite high. So it's about 800 milliequivalents per day. So based on that, the majority of filtered potassium gets reabsorbed. Okay, so we reabsorb the vast amount of it. Remember, we may lose a little bit of it in the stool, maybe about 5 milliequivalents, and the rest of it is going to be handled by the kidney. So what comes out in the stool is sort of unregulated, and we don't want to lose too much, and this is why you lose potassium with diarrhea. But really where the regulation occurs is in the kidney, and that's why we're spending time on it right now. So the kidney is where potassium external balance is variable and highly regulated. We're going to talk about that, okay? So for renal potassium handling, we're going to have to go back to the nephron, but I want to introduce two conditions, basically. There's condition one, which means we don't have enough potassium in our body. Maybe we've been stranded on a desert island and we don't have access to food. And so if we are depleted in potassium, we have to think about how the kidney would respond, okay? That's this condition. And then the other condition would be normal or increased potassium intake. In the depleted condition, well, we're still going to reabsorb 2/3 or 67% of filtered potassium in the proximal tubule. We're going to reabsorb about 20% in the thick ascending limb. Now, in the late distal convoluted tubule and collecting ducts, we're going to reabsorb as much as possible. So we're going to reabsorb another 3% of that filtered load. We're going to reabsorb 9% in the collecting duct. So very little of ingested or filtered potassium comes out into the urine because we do not want to excrete potassium, okay? So in potassium depletion, we're reabsorbing at every segment along the nephron, okay? That's because we want to hold on to it. Now the other condition, normal and increased potassium intake. Look at this. We're still going to reabsorb 2/3 in the proximal tubule. We're still going to reabsorb about 20% of the filtered load in the thick ascending limb. But here's the difference. In the late distal convoluted tubule and cortical collecting duct, now we're secreting potassium. So you see how the arrows are in different directions. Now we're secreting potassium into the lumen. And this is in order to stay in balance. And so the excretion of potassium is quite variable. And this is what we do in response to just normal or increased potassium intake. If we ate food that was extraordinarily rich in potassium and we didn't eat it all, we need to be able to excrete it. And this is how the kidney does it. So for a lot of the other electrolytes, we've been showing you sort of standard reabsorption rates. Potassium's different because we got two conditions and things change. Where do they change? They change in these more distal segments. So the big picture here is that in the proximal segments, even in both conditions, in the proximal tubule and loop of Henle, it's kind of steady and unregulated reabsorption. Like no matter what is going on, we're going to reabsorb stuff in these segments. We're going to reabsorb potassium in the same amount in these segments. All right, in the late distal convoluted tubule and cortical collecting duct, this is where it is highly regulated with variable excretion and reabsorption based on what you need. All right, so this is the big takeaway. Proximal tubule and loop of Henle is sort of steady, unregulated reabsorption of potassium, but the fine tuning occurs in the collecting duct in the late DCT. And I think, I mentioned this in the tubular function lecture that late DCT and cortical collecting duct, this is where the fine tuning occurs. Okay. Now, how does this happen? So you're looking at the principal cell again. Remember, this is where sodium is reabsorbed across ENaC channel, but potassium is secreted out of ROM-K. These gradients are maintained thanks to basolateral sodium-potassium ATPase. And potassium permeability is driven by this ROM K channel that sits here. And so this sodium reabsorption, right, because it's a chemical gradient, there's a lot of sodium here, there's very little inside the cell, so sodium will want to move into the cell, and by doing that, at that moment, it's generating a lumen negative potential, and this is going to help drive potassium to exit the cell, okay? The number of transporters here, and the activity of sodium potassium ATPase is all stimulated by aldosterone. So this is where the regulation comes into play. We got a hormone that will stimulate all this. And you can turn hormones on and off, and that's the benefit of hormones. Now let's talk about potassium reabsorption. So remember, if you're a patient with low potassium, if you need to hold on to potassium, you got to have a way to do it, and it happens at the intercalated cell. So you've seen this before. So remember, at the intercalated cell, there is a potassium hydrogen ion or proton antiporter or countertransporter where energy is required. So it's an ATPase, takes energy to bring a potassium into the cell, but it pumps out a proton. Okay, so it's an active process. You lose a proton in the urine, but you reclaim that potassium. And so this is the segment that would be activated with hypokalemia. So low extracellular potassium, we need to hold on to potassium. This is how the kidney would reabsorb potassium, okay? So it's an active process. This is where potassium reabsorption is occurring. And one thing to keep in mind is that aldosterone, remember aldosterone has effects on the principal cell. It drives everything. It will increase expression of ENaC and ROMK and the ATPase. But if the principal cell, imagine there's a principal cell right above the cell dumping, tons of potassium here, it will actually stimulate some of this process. It will stimulate hydrogen ion secretion. Okay, so in settings where aldosterone is very active and very high, there can be some exchange, or there will be some exchange of potassium with protons, and you will lose protons into the urine. And this could be even inappropriate. And so what I mean is like inappropriate secretion of aldosterone, like aldosterone secreting tumors, it leads to a metabolic alkalosis because you have inappropriate secretion of protons, okay? So my point is that even if aldosterone is very active in times where it's trying to get rid of excess potassium, the net effect is that there's loss of potassium into the urine. I don't want you to think that every single potassium that gets spit out is immediately taken up by this cell, okay? Because remember, this cell is also under regulation thanks to pH and acid-base balance. Okay, let's talk about the regulation of renal or kidney potassium handling. So first, we'll talk about what we call the peritubular factors, sort of like systemic factors and hormones and acid-base balance that can affect how the kidney handles potassium. So first, basically the plasma potassium concentration and aldosterone are related. So let's look at this. So what I'm showing you is a graph of saying what does the plasma aldosterone concentration do as a result of plasma serum potassium. So at very low potassium concentrations, aldosterone is suppressed. As serum potassium increases, that directly stimulates the adrenal gland to produce aldosterone, okay? So this is the relationship I want you to keep in mind. And so what's happening? Well, now we're looking at urinary potassium excretion, and this is sort of how many times normal based on the rise in aldosterone. And I know this is kind of a funny graph, but bear with me. So looking at the aldosterone line, you can say based on how many fold normal on the plasma aldosterone concentration. So you can see as plasma aldosterone goes up, you excrete more potassium. Well, why is that? Well, there are adaptive changes in the kidney. So we increase potassium secretion in the collecting duct. We increase principal cell activity by increasing the activity and the number of sodium potassium ATPase channels there, or transporters. And we increase sodium and potassium channel transport by increasing the number of those transporters. And the surface area of the basolateral membrane in principal cells increases, and it also will inhibit potassium reabsorption by those intercalated cells. So all this is driven by aldosterone. So the more aldosterone the more urinary potassium excretion. Okay, so this is driven because potassium concentrations will directly stimulate aldosterone secretion, and this is an effect that's independent of angiotensin II, because angiotensin II is another thing that can stimulate aldosterone production. Okay, now keep in mind also just the the filtered load of potassium surely would make a difference, and you can imagine a difference in potassium excretion. So you can imagine if the extracellular potassium concentration is extraordinarily low, right? I mean, like 1, 2, 3, less than 3 would be pretty low. You can see that there's very little potassium excretion, and that's appropriate. Okay, and that's because aldosterone would be suppressed. So look at this end of the curve here. So, but you can see that as soon as extracellular potassium concentration starts to rise, and it looks like we got an inflection point right here between 3 and 4, and it really starts to take off. That's when you start to see more urinary potassium excretion, and all this is driven by aldosterone. We do have some histological evidence of this. So these are animals fed on a low potassium diet versus a high potassium diet, and you can look at tubular cells in the collecting ducts, and you can see that on a high potassium diet, these tubular cells or principal cells in the collecting duct, they have more mitochondria, they're thicker, they're more energetically active. You can see that they're really revved up and ready to do some work. And so it's just histological evidence that aldosterone is causing cellular changes that you can see under electron microscopy. So what's really happening at the sort of the next level of detail? So we've told you that aldosterone will stimulate potassium secretion, okay, and it's putting more ENaC channels at the lumen, okay. It's stimulating the sodium-potassium ATPase, okay. It's upregulating all these genes involved in this process. So ENaC, ROMK, sodium-potassium ATPase. And it's because the mineralocorticoid receptor is an intracellular receptor. When aldosterone binds to it, it translocates to the nucleus, and it will upregulate all these genes. And so the net effect is that we have increased sodium reabsorption and increased potassium secretion. Okay. Now, how does pH, so how does acid-base balance factor into this? So we've already introduced this internal balance concept. And remember, the internal balance concept was that changes in the extracellular pH or hydrogen ion concentration will produce some reciprocal shifts in potassium and between these two compartments. So what I mean is, if we have an excess of protons outside of cell, protons will move into the cell in order to help buffer that, but it has to exchange for something, and it exchanges for potassium. Okay, so if you move a proton from out to in, a potassium goes from in to out. The opposite is true too, okay? If you move a proton from in to out, a potassium goes from out to in, okay? So we talked about that earlier in the context of internal balance, and that's something that can happen all over your body in all the cells. So now we're talking about external balance. We're just talking about what are the consequences of that when it happens at principal cells. All right, so let's run that experiment. What would happen if we start doing this shifting stuff on tubular cells that are doing all this work? Well, let's think about acidemia. Okay, so a metabolic acidosis is a problem where there are too many hydrogen ions in the plasma. So here, imagine we have tons and tons of protons. We need to buffer those, so we're going to shift them into cells in exchange for potassium. So at the principal cell, if we are removing potassium from the cell that would otherwise be there, now we have fewer potassium ions to be secreted. All right, so acidemia decreases intracellular potassium, and when this happens in the principal cells, it will decrease potassium secretion. That's it. That's all you got to know. So this internal balance stuff is happening all over the body, but when it happens, including in tubular cells, well, now it can affect external balance too. Okay, because now we're inhibiting potassium secretion because there's less to secrete. We have to have it in here first before we can secrete it. Okay, now the opposite is true for alkalemia. So in alkalemia, metabolic alkalosis, the pH is way too high. Bicarbonate concentrations are too high, and consequently, that means proton concentrations are very low. All right, that means we don't have enough protons out here, so we can actually buffer by moving protons from in cells to outside of cells. What are the consequences of that? Potassium will move from outside of cells to inside of cells. So we actually start packing more potassium into cells. So in addition to the ATPase working, we're doing some shifting on this side and we can pack potassium into cells. What are the consequences of that? Increased potassium secretion, because now that chemical gradient was accentuated. All right, so this is how pH and proton concentrations in exchange for potassium can affect external balance. Here's a graph just showing you the relative contribution for some of these factors. So you can see as we increase the plasma potassium, we excrete more potassium, which makes sense. We just told you that, and that's driven by aldosterone, because aldosterone is stimulated by potassium hyperkalemia. Now, what if we change the pH? And so you can see that we get more potassium secretion based on the plasma potassium with a more alkaline or alkalotic pH. We get less potassium secretion with a acidemic or lower pH. All right, and I think I just explained why that would be. Okay, next, let's talk about some the luminal factors, basically what's happening in the tubular lumen. The things we just talked about were sort of systemic, or things happening around the tube. Now we're talking about what's happening in the tube at the level of the lumen. The two things here, distal tubular flow rate, like literally what is the flow of fluid past the principal cell, and then how much sodium is being delivered. These two factors drive potassium secretion. An increase in the flow rate increases potassium secretion, and this is sort of like minute-to-minute regulation. And so when we administer diuretics and urine flow rates increase, you're going to lose more potassium. And as you can imagine, in order to stay into balance, if you underwent extracellular fluid volume expansion and are not reabsorbing lots of sodium and water because you have enough, urine flow will increase, and that will promote potassium secretion. The mechanism for this is because there is a primary cilium on all these cells. And I know when we draw these cartoons, we leave it off all the time. And so what is actually there is this primary cilium. And when flow is high, it bends it more. And that will increase calcium influx into the cell, which will directly stimulate the ROMK channel and help open it up. Okay. So here's flow rate and potassium secretion. You can clearly see that with more flow, you get more potassium secretion. Alternatively, the more sodium you deliver to the principal cell, the more potassium secretion. And this should be pretty intuitive, I think, when you think about the principal cell. There's the ENaC channel. It needs sodium, right? The more sodium, the more substrate you show to that region, the more sodium goes into cells, and then it's going to really drive potassium secretion. But remember, you have to have potassium into the cell, and that's why the ATPase is there. So with more distal sodium delivery to principal cell, you get more potassium secreted. With more flow, you get more potassium secreted. And here's a graph essentially showing you that same thing, basically how much potassium is being secreted here based on the flow rate. And you can see, again, we told you that potassium intake drives potassium secretion, but for every condition, you can see that you do get more distal potassium secretion with higher flow rate, except for maybe on a very low potassium diet when you need to conserve potassium, right? So our body's pretty good at regulating this, right? Even if we're on a potassium restricted diet, it'll try and hang on to potassium independent of flow. So it's kind of interesting. So basically on a high potassium diet, you want to make sure that you have a good urine flow rate and distal sodium delivery to keep things in balance. Otherwise you get into problems. So I'm just summarizing it all again in a picture form. Okay, so imagine the principal cell. Increased sodium delivery will accelerate potassium secretion. All right, and we do this clinically sometimes. If we have a patient with high potassium and we got to figure out how to get potassium out of their body, well, it's like, hey, how do we deliver more sodium to the principal cell? How do we get more sodium down the tubes and get sodium as substrate to the principal cell to do this exchange? So this is one way we think about it. So distal sodium delivery is a key concept. Now I've added the primary cilium to our cartoons. So we always leave this off of our cartoons, but now it's important, so I'm going to show it to you. So imagine there's this sort of flow sensor, this primary cilium, and so as urine is flowing, right, urine can go slow, it can go fast. As there's high flow, it bends it, and that will increase calcium influx locally, and that will stimulate the ROM-K channel. So increased flow here will increase potassium secretion, okay? And remember, the thing that's on the back end is aldosterone, okay? Aldosterone turns all this on, and aldosterone, when it's absent, can slow all this down, okay? So this is the regulatory factor here. So here's the summary, all the factors that influence urinary potassium secretion. So the plasma potassium concentration, the filtered load of potassium, aldosterone, acid-base balance, so what's the pH, distal sodium delivery, and tubular fluid flow rate. All right, so while we're on this subject, just to make sure you get some of these concepts, we do have some clinical uses for blocking some of these channels. So we have a class of drugs, medications called potassium-sparing diuretics. So these are medicines that will inhibit sodium reabsorption, but they spare the loss of potassium. And so the only way to do that in the kidney is to somehow block principal cells, to shut them down in some way. And so one mechanism is by inhibiting ENaC, and you can do that with amiloride or triamterene. Okay, so these drugs will block ENaC. They're not really great diuretics because think about the distal sodium that's made it this far. It's not that much of the total filtered sodium, but we use these sometimes to counterbalance hypokalemia that's occurring from using loop diuretics or thiazide diuretics. So sometimes we add these on if to those other diuretics if we really need to use the first diuretic, but we don't want to cause so much hypokalemia. Okay, so when we give people loop or thiazide diuretics, they get hypokalemia because distal flow rates are so high, and we're showing a lot more sodium to the principal cell. So sometimes you can fix it all by using both a loop diuretic and a potassium-sparing diuretic like amiloride or triamterene. I'd say the class that's used most often is a mineralocorticoid receptor antagonist, and we got two of these. One's called spironolactone, the other one's called eplerenone. And these are used, I'd say, more often than the ENaC inhibitors, and it's helpful. It blocks aldosterone, so it's a potassium-sparing diuretic, and there's actually some really good data. There's mortality benefit when it's used in patients with heart failure with reduced ejection fraction. So, shutting down these hormones when it's a maladaptive response has been shown to have a beneficial effect. So here's the main synopsis. I think we covered all these topics, and look forward to seeing you put these concepts into action. Thank you.